بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is a new topic in the imaging of the musculoskeletal system, and this topic is about the arthropathies or joint diseases. And you know that there are a lot of joint diseases that can occur under this title, and I will show you some of the enumeration of just of these diseases, and I also will tell you what will be covered by this talk. Sorry. The evaluation of the arthropathies will include these items: polyarthritis of unknown etiology, connective tissue disorder, biochemical and endocrinal arthropathies, degenerative joint disease or osteoarthritis, arthritis related to inflammatory bowel disease, infectious arthropathies or septic arthritis, traumatic arthritis, neuropathic or Charcot joint, neuropathic arthropathy, of course, neoplastic arthropathies, and some miscellaneous disorders. Under each of these items, there are a lot of subdivisions, and in cases of polyarthritis of unknown etiology, there are rheumatoid arthritis, juvenile rheumatoid arthritis, including Still's disease, ankylosing spondylitis, psoriatic arthritis, Reiter syndrome, and some other issues. The connective tissue disorders will include the systemic lupus erythematosus, progressive systemic sclerosis or scleroderma, polymyositis and dermatomyositis, necrotizing arthritis, and other forms of vasculitis, including polyarthritis nodosa, hypersensitivity angiitis, and Wagner's granulomatosis. Arthritis associated with biochemical and endocrinal abnormalities include gout and pseudo-gout, alkaptonuria, hemophilia, sickle cell disease, hyperparathyroidism, acromegaly, thyroid acropathy, hypothyroidism, scurvy, and hypovitaminosis C. Degenerative joint disease will include primary and secondary osteoarthritis as well as erosive osteoarthritis. Arthritis related to inflammatory bowel diseases such as ulcerative colitis, regional enteritis or Crohn's disease, Weber's disease, Sjögren, and sarcoid. Infectious arthritis or septic arthritis, whatever the etiology, will be also discussed here. Traumatic arthritis and neuropathic arthropathy or Charcot joint. These are the causes of neuropathic arthropathy, including neurological changes such as syringomyelia, meningomyelocele, spina bifida, spinal trauma, diabetes, brain injury, leprosy, and so on. Neoplasms related to the joints will include the synovial sarcoma, synovial lipoma, hemangioma, plexiform neuroma, synovial chondrosarcoma, metastatic diseases related to the joint, and some of the primary juxta-articular bone tumors, leukemia, lymphoma, and myeloma. Miscellaneous disorders will include the pigmented pillonodular synovitis, synovial osteochondromatosis, synovial arteriovenous malformation, Behçet disease, vascular necrosis of the bone and bone infarctions, juvenile osteochondritis, osteochondritis dissecans, and finally hypertrophic osteoarthropathy. So you see a lot of items that are included under this very huge topic. So I will divide this talk into 3 or even 4 parts, and I will discuss in the first part of this presentation the issue of rheumatoid arthritis, juvenile rheumatoid arthritis, as well as ankylosing spondylitis. Starting evaluation of joint diseases by imaging. This is a list of what can happen if the joint is involved. And of course, you will not see all these items in a single joint at a time, but there may be some early manifestations including so and so, then late manifestations including other items, then very late manifestations including the rest of the presented items. These items include number one, juxta-articular osteoporosis, or decreased bone density of the bones near the joint, here in the articulating bones. Then joint space widening, which is usually secondary to synovial hypertrophy and joint effusion. Also, joint effusion is a manifestation of joint disease, loss of bone density, joint space narrowing due to erosion and the destruction of the articular cartilage, articular erosions, bone resorption, bone sclerosis, osteophytes, as in cases of osteoarthritis, periosteal reaction, soft tissue calcification, subluxation, dislocation, disorganization, and finally loss of the joint by ankylosis, which is first by fibrous ankylosis, then follow total bony ankylosis of the joint. This is the first group of polyarthritis of unknown etiology, which include rheumatoid, juvenile rheumatoid, ankylosing spondylitis, psoriatic arthritis, Reiter, and others. As I have mentioned, I will discuss this one and this one and this one in the first part of the talk of arthropathies. Rheumatoid arthritis is a chronic non-suppurative inflammation with an age average about 40 years. There are some of the classic clinical manifestations of rheumatoid arthritis, which include morning stiffness, pain or tenderness in at least one joint, soft tissue swelling in one joint, also symmetrical joint swellings on both sides may be seen, subcutaneous nodules, and at least one of the findings in the plain X-ray, which is the juxta-articular osteoporosis. Rheumatoid arthritis is known as the seropositive disease because of the presence of rheumatoid factor, which is an antibody in the serum of the patient, and this rheumatoid factor is positive in about 90% of the patients with rheumatoid arthritis. And the severe disease correlates with high serum titers of rheumatoid factor. But you should also know that this rheumatoid factor may be positive in about 4% of the normal population, and it can be seen in other diseases like systemic lupus, scleroderma, dermatomyositis, and polyarthritis nodosa. Rheumatoid arthritis, as I have mentioned, has an age average about 40 years between these two figures. It usually affects females more than males, and this is a polyarthropathy, which is usually bilateral and symmetrical, affecting mainly the small joints of the hands and feet. The early manifestations of rheumatoid arthritis will be periarticular osteoporosis due to hyperemia and some disuse of the hands and feet. This periarticular or juxta-articular osteoporosis is seen in the head of the metacarpals as well as the base of the proximal phalanges, and also maybe around the interphalangeal joints. Widening of the joint space due to synovial hypertrophy and maybe effusion, periarticular soft tissue swelling, which is the fusiform soft tissue swelling around the affected joints. The causes include the presence of joint effusion, hyperplastic synovitis, and periarticular soft tissue edema. Then rheumatoid arthritis particularly affects the metacarpophalangeal and the proximal interphalangeal joints and all joints around in the rest. The radiocarpal, the intercarpal, and the carbo-metacarpal joints. Early in the disease, you will see very articular soft tissue swelling, which can also be appreciated in the plain X-ray. You may see some decreased bone density around the affected joints. And this is an example. I have mentioned that the decreased bone density is usually due to hyperemia and disuse. Then if you look carefully here, and you can see some loss of bone density around the metacarpophalangeal joints as well as around the wrist joint. Then erosions will start early in the disease, and these erosions will not affect the articular surface at the beginning. They occur near the articular surface and may be more appreciated on the radial aspect of the joint. But it's also mentioned in the literature that affection of the fifth metatarsophalangeal joint is usually an early manifestation of rheumatoid arthritis in the foot. And bone erosions will enlarge and will go into the articular surface. It will affect the articular surface of the joint on both sides, and this may result with in narrowing of the joint space, as you can see here and here. Then later changes of rheumatoid arthritis will include the erosions with consequent joint space narrowing, and one of the manifestations of rheumatoid is the subluxation, including the ulnar deviation at the level of the metacarpophalangeal joints and soft tissue atrophy. Then if you look to this case of rheumatoid arthritis, and you can see significant narrowing of the radiocarpal and ulnocarpal joints with bone sclerosis and the erosive changes of the carpal bones. Also, you can see the erosions affecting the metacarpophalangeal joints and some of the proximal interphalangeal joints. Then this syndrome is Felty syndrome is just a triad of three main issues. Number one, the presence of rheumatoid arthritis. Number two, splenomegaly, and decrease white blood count. Of course, you know that this will enhance the possibilities of infection, as you can see in this image. Then Felty syndrome is just the rheumatoid arthritis with leukopenia or decreased blood leukocyte count and the enlargement of the spleen. This is present in less than 1% of the population, and frequently seen in patients with rheumatoid arthritis of more than 10 years duration, and this is the age incidence. Then in the x-rays you will see the changes of rheumatoid arthritis. In order to diagnose Felty syndrome, you should know that the spleen in this patient is enlarged, and also the white blood count is significantly decreased. Then the important landmarks of rheumatoid arthritis will include bone erosions, which affect the articular surface late in the disease, joint space narrowing, destruction of the articular surfaces, and the subluxation. And here you can see some of the changes in the intercarpal joints with loss of the joint spaces, bone erosions, and all these changes are also well appreciated in the metacarpophalangeal joints. MRI is not usually needed for evaluation of patients with rheumatoid arthritis, but you know that MRI is more sensitive for bone marrow changes. and also for the detection of synovial hypertrophy and inflammation. And this is an MRI with T1 weighted image and T1 fat suppressed weighted image after contrast injection. You can easily appreciate the bone erosive changes in the ulna as well as in the triquetral bone, also the lunate and the discified. Then after injection of contrast, you can see the hypertrophied synovium, which is considerably enlarged and also extends into the distal radioulnar joint. And this is a case of advanced rheumatoid arthritis by MRI. You can see narrowing of the joint space, bone erosions of the radius, and the most of the carpal bones. Then you can also, if you inject contrast, you can see the synovial inflammatory changes. Rheumatoid arthritis, as you all know, can also affect the large joints like the knee, the shoulder, the ankle, and so on. And one of the major manifestations of rheumatoid arthritis in these large joints is mere joint space narrowing without bone erosions in most of the cases, but sometimes you can see bone erosive change. Of course, you know that this is not an osteoarthritis because in cases of osteoarthritis, you have to see some osteophytic clipping, and you get non-symmetrical narrowing of the joint space affecting mainly the medial aspect of the joint. Sometimes you can see subarticular pseudocystic changes. Then this is one of the manifestations of rheumatoid arthritis, which is synovial hypertrophy, thickening, and enhancement. In the T1 weighted image, you can see these low signal structures which has been enhanced after contrast injection in this T1 weighted image post contrast, representing synovial hypertrophy, thickening, and enhancement. And this is the case of rheumatoid arthritis of the knee, involving mainly the synovium. This is the synovium in the T1, in the proton density, and in the T2 weighted image. And you can appreciate the degree of synovial hypertrophy and in the masses in the popliteal fossa and also in this particular area. You know that there are some of the specific deformities in rheumatoid arthritis affecting mainly the hand. And the well-known two deformities are the swan neck deformity and boutonniere deformity. In boutonniere deformity, there is extension of the distal interphalangeal joint and deflection of the proximal interphalangeal joint. In the swan neck deformity, there is the opposite, flexion of the distal interphalangeal joint and extension of the proximal interphalangeal joint. This is a case of ulnar deviation secondary to rheumatoid arthritis, and you can see the subluxation of the metacarpophalangeal joints. Also, in the rest, you can see severe narrowing of the intercarpal and radiocarpal joints, as well as some bone erosions and the sclerotic reaction of the articular surfaces. These are the two deformities, the boutonniere deformity with extension of the distal interphalangeal and the flexion of the proximal interphalangeal, and this is the swan neck deformity, which is the opposite of boutonniere. Ulnar deviation is one of the well-known manifestations of deformities secondary to rheumatoid arthritis, and this is a case of rheumatoid arthritis, and you can see the subluxation of the metacarpophalangeal joints. And this is also a case of rheumatoid arthritis. You can easily appreciate the erosive bony changes, and you can also see the significant subluxation of the metacarpophalangeal joints. The related changes in rheumatoid arthritis will include the secondary osteoarthritis and sometimes bony ankylosis and what is known as arthritis mutilans. This arthritis mutilans means that there is extensive destruction of the joint with telescoping of the finger and consequent shortening, as you can see here. And this is a severe advanced case of rheumatoid arthritis with destructive changes in the radiocarpal joint, almost bony ankylosis of the intercarpal and the carbo-metacarpal joints. And you can also see this deformities which if progressed will result in telescoping of the finger or arthritis mutinans. A case of bony ankylosis secondary to advanced rheumatoid arthritis affecting the wrist joint with obliteration of most of the intercarpal joints, marked narrowing of the radiocarpal joint. And this is also a later changes of rheumatoid compared to the normal appearance of the wrist joint. There is loss of most of the intercarpal joints, some bone erosions of the articular surface of the radius compared to the normal appearance. And this is also a severe case of rheumatoid arthritis with erosion of the distal end of the ulna, bony ankylosis of the intercarpal joints as well as the carbo-metacarpal joints. In the ankle, there are a lot of manifestations of rheumatoid arthritis, starting from synovitis, then erosive changes, then bony ankylosis, and secondary osteoarthritic changes. You know that there is a bursa between the tendo-Achilles insertion site in the calcaneus as well as the posterior aspect of the calcaneus. And this bursa is usually affected in cases of rheumatoid arthritis by synovial hypertrophy and effusion. Then you may not appreciate this in the plain X-ray, but this is well appreciated in the MRI T1 and the stair-weighted images. And you see there is a significant synovial hypertrophy that has eroded the insertion site of the Achilles tendon in this area. And this is the appearance of the bursa and the appearance of the involved tendon. In the plain X-ray, you may not be able to appreciate the changes of rheumatoid arthritis if they are early, but this is the value of MRI where you can see the erosive changes in the bone, and you can see also the synovial hypertrophy and soft tissue edema. This is also appreciated in the axial images compared to the normal side, and you see the synovial hypertrophy and the soft tissue inflammatory changes. One of the pathognomonic features of rheumatoid arthritis is the presence of what's known as rice bodies. And these rice bodies are minute low signal lesions within the affected joint, surrounded by joint effusion and the synovial hypertrophy. In this case, you can see some enlargement of the popliteal lymph nodes, which are not usually associated with rheumatoid arthritis. And also this fat suppressed T1 weighted images, you can see significant or marked thickening of the synovium and enhancement as well. And this is also appreciated in the sagittal image as well as in the axial image. Of course, you can see the rice bodies in the T2 where the fluid of the effusion is of bright signal. Then, as I have mentioned, the presence of rice bodies is considered as a very characteristic feature of rheumatoid arthritis. This is MRI of the shoulder, and you can see the distension of the joint capsule by fluid and the numerous low signal loose bodies within the joint capsule. Rheumatoid arthritis also affects the spine, particularly the cervical spine. And you all know one of the early manifestations of rheumatoid arthritis is the widening of the atlantoaxial joint space. You know that the distance between the anterior mass of the atlas and the odontoid process does not exceed in normal conditions 3 millimeters. In cases of rheumatoid arthritis with affection of the ligaments and subluxation of the joints, you can see widening of the atlantoaxial joint without bone erosions as an early manifestation. Later on, you got affection of the facet joints and also the spinous processes, which may result in total occlusion of the facet joints in some advanced cases. Also, beside the affection of the atlantoaxial joint, there may be involvement of this disc space in particular, which is the C4-5 level, as you can see here with erosions and maybe subluxation. Then intervertebral disc space narrowing may occur due to erosive changes, ankylosis of the apophyseal joints, and you know these are the normal apophyseal joints, and here you may see some ankylosis of the apophyseal joints. Also, there may be some affection of the sacroiliac joints. Juvenile rheumatoid arthritis means that this is the rheumatoid arthritis occurring early in life, and this rheumatoid arthritis is usually a monoarticular disease, which is a common manifestation compared to the polyarticular disease of the adult type of rheumatoid arthritis. Also, one of the manifestations is the presence of preosteal new bone formation. If you look in the hand, and you can see around the phalanges, and you can see also around the metacarpals. Due to hyperemia, there may be premature appearance of the ossification centers, and there also may be overgrowth of the epiphyses with early fusion. And this is the case of juvenile rheumatoid arthritis, showing hyperemia of the around the joint with consequent loss of bone density, or what is known as juxta-articular osteoporosis. According to the literature, this may be the only finding in cases of juvenile rheumatoid arthritis. Then if you look here, and you can see significant decreased bone density around the metacarpophalangeal and the wrist joint, which is usually associated with enlargement of the epiphyses due to hyperemia, and maybe early fusion of the epiphyses as well. Rheumatoid arthritis in the juvenile type, few or minority of the patients are rheumatoid positive, and these rheumatoid positive patients may show early erosive changes of the bones, and this is bilateral glenohumeral juvenile rheumatoid arthritis, with you see the decreased bone density, the narrowing of the joint space, and bony erosive changes in the humeral head, especially on the left side. Also, if you have the facilities to examine the patient by MRI, and you may inject the contrast media, then you can see the degree of synovial thickening, which is affecting the synovial sheath of the tendon, and also it can be seen in around the carpal intercarpal joints, as well as in the distal radioulnar joint. Sometimes the rheumatoid arthritis in the knee, as I have said, it will result in absolute narrowing of the joint without bone erosions. But in cases of juvenile rheumatoid arthritis, you may get some joint effusion, and you can see hypoplasia of the menisci and widening of the intercondylar notch, which is secondary to synovial hypertrophy and erosions. Also, in the wrist, you may not be able to appreciate bone erosions by the plain X-ray, and you can see these erosions better on MRI. Juvenile rheumatoid arthritis, as I have mentioned, may affect the large joints, and it will result in a significant decrease in the joint space. And here you can see bilateral rheumatoid arthritis of the hip joints with marked narrowing of the joint space, and some are erosions of the femoral head and the neck. You know that the femoral neck is an intra-articular component. Then the next arthropathy is the ankylosing spondylitis, and this is a chronic progressive arthritis, affects males predominantly. About 90% of the patients are males, and this type of arthropathy has an intimate relation to HLA-B27 antigen, which is present in most of these cases. Affection of the sacroiliac and apophyseal or facet joints is one of the standard manifestations of ankylosing spondylitis. This plain X-ray shows the normal sacroiliac joints in the frontal view and in the oblique view for each joint. And here you can see the normal sacroiliac joints by plain X-ray and by coronal reformatted CT image of the sacroiliac joints. And this is also the normal appearance of the sacroiliac joint by MRI. Then HLA antigen is the human leukocytic antigen, which is present in about 90% of patients with ankylosing spondylitis. This HLA-B27 can also be seen in Reiter syndrome and some patients with psoriatic arthritis, especially those affecting the spine. Then whenever you see an image or an X-ray like this, and you can see bilateral affection of the joint, of the sacroiliac joints, in the form of narrowing of the joint space, subarticular bone erosions, and subarticular bone sclerosis. And this is known as bilateral sacroiliitis. And if you look carefully to the right sacroiliac joint, you can see that there is almost total loss of the joint space amounting to ankylosis. And whenever you see some manifestations of ankylosing spondylitis, then you can call the affection of the sacroiliac joints to be related to the ankylosing spondylitis. And you remember this term, the Mamdouh spine, where there is some erosive changes in the anterior corners of the vertebral end plates, upper and lower, with consequent calcification and later on ossification of the anterior longitudinal ligament, posterior longitudinal ligament, interspinous ligament as well. Then in the frontal view, you can easily appreciate the loss of the sacroiliac joint space and the calcification of the spinal ligaments all around. Then this is the normal appearance of the sacroiliac joints, and these are the sacroiliac joints involved by ankylosing spondylitis. Ankylosing spondylitis affecting the sacroiliac joints will show bilateral and symmetrical manifestation. The joint margin will be ill-defined. Some osteoporosis may be seen around the joint, but dense reactive bone sclerosis is usually the manifestation. Then later on you got ankylosing of the joint, early by fibrous and late by bone. Here you still appreciate the presence of some of the joint space bilaterally, but it's easy to see the loss of the joint space and the bone sclerosis on either side of the joint space as well. Of course, the CT scan is good in appreciation of the degree of ankylosis of the sacroiliac joints. Here you see total obliteration of the joint space by bony ankylosing bilaterally. Early in the MRI, you can see bone marrow edema in the sacral and the iliac sides of the sacroiliac joint. And of course, bone marrow edema will show bright signal in the T2 and the stair-weighted images compared to the normal appearance of the sacroiliac joints. Then, it's not a good policy to have an MR examination of the sacroiliac joints looking for early manifestations of ankylosing spondylitis. Then, since the diagnosis is usually made by clinical and laboratory findings, then if you want to see these changes, then you will have some bone marrow edema showing low signal in the T1 and the high signal in the T2 and the stair weighted images. The dagger sign means that there is a longitudinal midline calcification along the, of course, the interspinous and the supraspinous ligaments. Also, you can see the degree of loss of the sacroiliac joint spaces, and also affection of the hip joints, which is more severe on the right side. This is the classic appearance of Mamdouh spine due to ankylosing spondylitis. You see obliteration of the joint spaces in the sacroiliac region, calcification of all the spinous ligaments, anterior, posterior, intraspinous, lateral ligaments of the spine will end by this classic appearance of Mamdouh spine. In the cervical spine, ankylosing spondylitis affects early the facet joints. This is the normal cervical spine, and these are the facet joints which are intact. But here you can see that there is obliteration or ankylosis of all the facet joints in the cervical spine. Also, there may be syndesmophytes, which are osteophytes arising from the mid portion of the vertebral body, not from the vertebral endoplate. Disc degeneration with calcification, then kyphosis and subluxation. There may be also fractures affecting the spine, and because of the rigidity of the spine at that time. Then this is ankylosing spondylitis affecting the sacroiliac and the hip joints. You appreciate the degree of joint space narrowing of the sacroiliac joints, as well as the affection of the hip joints with significant narrowing of the joint space. In MRI, actually, you may see early changes in the erosion of the vertebral corners with focal areas of bone marrow edema showing the low signal in the T1 and the high signal in the T2 weighted images. The sacroiliitis condensans is a benign lesion which is manifested by sclerosis of only the iliac side of the sacroiliac joint. This is also bilateral and symmetric, but the joint space is not affected. The articular surface is intact, and also the sacral side is not affected by this disease. This is not a disease, but is a manifestation commonly seen in multiparous females, believed to be due to mechanical stress across the sacroiliac joints during delivery. But in this coronal reformatted image, you can see the degree of bone sclerosis affecting the iliac side of the sacroiliac joint. This condition is usually asymptomatic, but may be discovered when we are searching for a cause of low back pain in such cases. And of course, the differential diagnosis is the other causes of sacroiliitis. But you know that sacroiliitis, there should be affection of the joint space by narrowing and erosion. affection of the both sides of the joint space, including the sacral aspect as well as the iliac aspect of the joint. Alhamdulillah Rabbil Alameen, thank you very much.